everyone, and welcome to Talk Nerdy. Today is Monday, July 24th, 2023. I think I'm just getting to that age where every time I see the date, I'm like, how already? I want to apologize for not having an episode for you all last week. We sent out a message on social media, but I was out of town for 2 weeks doing some psychological services, some humanitarian work in Southern Africa, in Eswatini. And just leading up to the trip, we had some reschedules and we weren't able to get enough episodes, quote, in the can that we would have liked to. So we ultimately had to skip that week. Hopefully it was no harm, no foul. I did miss you all, but don't worry. On Patreon, if you are supporting the show on Patreon, you only pay for episodes that go to air, and so we are back in business now. Speaking of Patreon, I do want to thank those of you who make Talk Nerdy possible, because of course it's been a hard year with almost I shouldn't say almost no, but very little ad sales that you've probably seen across most podcasts. The podcast advertising industry is really taking a dive. So a lot of us are fully dependent on listenership from individuals just like you. And of course, the programmatic ads that we have that pay much less than the host-written ads. It's a whole thing. I'm not going to talk about it now. You could Google it if you want. It's not that interesting. But yeah, on Patreon, if you pledge your support, it's, it can cost 50 cents, $1, $5. I've got some individuals who are paying a lot more than that. And I'm just really, really grateful because on a per episode basis, it helps offset the costs of paying my assistant, of paying the editors on the show, and then, of course, of compensating me for my time on top of all the work I'm doing on my internship full-time, basically, as a psychotherapist and finishing my dissertation. So who are the top patrons this week? Almost the same as always, but I want to give them a shout out just the same. Daniel Lang, David J.E. Smith, Mary Neva, Brian Holden, David Compton, Gabrielle F. Jaramillo, sorry about that, Joe Wilkinson, Pasquale Gelati, and Ulrika Hagman. Thank you all so much. Let's talk about this episode. I'm energized, even though I'm jet lagged, and I think it's because this chat was incredible. I just finished recording, and now I'm recording the intro because I time travel on the show. I'm so excited to have met this brilliant and really warm individual, and her book is just so important. So her name is Dr. Ilana Yurkiewicz, and she is an oncologist and internal medicine physician who is on the faculty at Stanford Medicine. And she writes a lot. She's a medical journalist as well. So she's been published in all of the outlets. If you read science, all the outlets you love: Atlantic, Scientific American, Undark, even the Best American Science and Nature Writing, and a bunch of other places. She has a new book called Fragmented: A Doctor's Quest to Piece Together American Healthcare. And as I mentioned at the end of the show, which you have not heard yet, whether you are an American human being who utilizes the American healthcare system, or you're somebody who does not live in the U.S. and you are curious about how broken, how fragmented our managed care system is, this book is for you, and hopefully this episode whets your appetite about that a little. We grapple with a lot of really important things. So I'm going to stop babbling. Without any further ado, here she is, Dr. Ilana Yurkiewicz. Well, Ilana, thank you so much for joining me today.
Thank you for having me. I'm excited to talk to you today.
Me too. We're going to be talking about your new book, Fragmented: A Doctor's Quest to Piece Together American Healthcare. I mean, this is like one of the most important things we could be talking about right now. I feel like it's something that in my life is just a constant refrain, and I'm not sure that I have actually dedicated an episode of my show specifically to this topic before. So before we dive into your writing, let's talk a little bit about who you are, because you do write public, like science and medicine. You're published in a lot of outlets where public science communicators often write, like SciAm, Undark. You're in the Best American Science and Nature Writing, which is a volume I always read. But you're also an oncologist, an internal medicine physician. And you're on faculty at Stanford. So tell me a little bit about like what you studied in school and maybe like how you specialized? Because internal medicine and oncology, is that common?
So it's common to do internal medicine and oncology in that order, but then it is uncommon to end up where I've ended up in my clinical career, which is doing primary care with a focus on cancer patients and cancer survivors. So actually truly combining the internal medicine and oncology in one clinic to take care of the whole patient. So I will back up a bit. In college, I studied molecular, cellular, and developmental biology. But I always was interested in both the sciences and the humanities. And I had an inkling from an early stage in my career that I wanted to go to medical school and become a physician because I felt like becoming a physician would allow me to do both, to study the sciences deeply and then apply that humanistic instinct towards taking care of patients. And at the same time, back when I was in college, I also always had the itch to write. And I think in retrospect, that was because the skills that I use in medicine are actually quite similar to the skills that are at play in science journalism, which is you take complex ideas and you try to break them down for everyday people to understand and to make that kind of information accessible. And I try to do that in the exam room when I'm with my patients, and then I try to do that in my writing as well. So when I was in college, I wrote for my college science magazine and ultimately became editor-in-chief there. And then since then, I've had these two careers going on in parallel where I did go to medical school. And then while I was in medical school, I started blogging for Scientific American. And throughout my career, I freelanced for various outlets. And I feel very privileged to be in a position where I have this insider perspective on healthcare. And I can use that to write nuanced, responsible pieces that I hope my intention is to get at the heart of the issues that are going on in medicine and healthcare.
Yeah. I'm so excited to have you on the show because I just feel like I'm going to have to stop myself. I'm going to have to watch the clock for this conversation because we could just go, go, go. And I'm going to be that annoying person who hits you up after and like to hang out, especially when I come back to California. I'm in SoCal, you're in NorCal, but yeah, we'll make it work. So I've long thought about, I'm working in, I'm finishing my internship, which is in geropsychology. But before that, all of my, practicum training, not all, but the practicum training that I really focused on was in psycho-oncology, and that's where I'm going to postdoc is back in LA at Cedars within a few months. I think very often, and I've seen very often with my clients, the need for them to have, I almost think of it as like, with my trans clients, they need trans affirming doctors. With the clients that I work with who have cancer, they need dentists who understand somebody post radiation. They need they need PCPs who understand the complexity of what it means to either be living with cancer, to be, no evidence of disease post cancer, what kinds of things they need to look for. It's just, healthcare is so fragmented. I mean, I know that's why you wrote this book. I'm so excited to get into it.
I am so excited to hear you say that and to hear about your career, because I will just say very, very briefly about mine. What I'm doing clinically is not a typical career path by any stretch of the imagination. So even taking aside the journalism component of it, when I finished all of my training, which was 4 years of college, 4 years of medical school, 3 years of residency in internal medicine, and then 3 years of fellowship in hematology and oncology, the normal thing to do is to join an oncology practice. But I felt like I wanted to play a bigger part in directly helping the fragmentation that I write about in this book. And I saw a scenario so many times where my oncology patients were kind of shuttled back and forth between the oncologist and the primary care doctor, where once they were cured of their cancer, their oncologist would say, go back to your primary care doctor. And then the primary care doctor would see them and say, but I'm not trained in all of the chemotherapy and other treatments they've received and what could happen next. And so I did the radical thing, which was to open a primary care practice with a special focus on cancer patients so that I could try to meet all of their needs in one place.
I love that. I mean, in a way, and I'm going to get a little personal for just a second, but in a way, I feel like I had a taste of that with my own diagnosis, but not completely, because my gynecologist, my OBGYN, she, the listeners of the show hopefully already know this. If you don't, I can send you back to some episodes where I talked about it at length. I'm not going to take up too much time doing that. But last year I was diagnosed with oh gosh, it's cervical cancer, but it's not cervical cancer. It's sometimes called stage 0. And why? I'm so tired right now. I'm jet lagged from a trip. I'm blanking on what it is called. Adenocarcinoma in situ. So I was diagnosed with adenocarcinoma in situ. The treatment is total hysterectomy. And luckily, my gynecologist happens to have fellowshipped in laparoscopic surgery. And she got to be also my surgeon. And she got to be with me every step of the way, from all the colposcopies I had over the years to the final diagnosis. She was the one I trusted. She was there in the OR with me. She was there when I woke up. She's there for my aftercare. And I know that, if unfortunately it recurs and I do have to move on to oncology, I am going to need a new practitioner. But it was so meaningful for me to be with the same person who knew my health history and who knew me as a human being.
Yeah, that it makes such a difference. And I mean, I'm so sorry that happened to you, and what an experience. But the experience you had with your doctor was actually quite rare, as I'm sure you know, that people often, when they get very sick, they end up seeing a lot of different doctors. And it's like you're repeating your medical histories to dozens of new faces on a regular basis. And you don't often have that primary point person, that primary doctor who is with you throughout. Usually it's, okay, go see the radiation oncologist now, go see the medical oncologist, go see the surgical oncologist, go see the gynecologist. And I'm glad you had that experience. I wish it was more common.
I do too. I know that at the hospital where I have worked in the past, they have a lovely outpatient cancer facility that at least has, under the same roof, psychiatry, social work, nutrition, rehab medicine, some palliative care, as well as like ancillary, like the dietitians and things like that. And that's really lovely to see that it's all in the same place where the clients, or patients, I should say, go to get their infusions. But on sort of the medical side, and I know I did include rehab medicine and palliative there, but on the other medical side, I still think it's fragmented, because that's just traditionally how things are run. It's nice when you have that center spoke. I like to think of it that way, that center spoke of the wheel, who can help guide. Because I can tell you, more often than not, when I was working with individuals who had cancer, some of what we were processing was the psychological components, right? The existential suffering, the fear, the anxiety. But some of what we were processing was just the exhaustion from the logistics. And I hate to say this, the stress, the financial stress.
Yeah.
Like sometimes that was out in front of the fear of death.
Absolutely. And I see this in my patients all the time. And it's really cruel. And I think it's really tragic that when you are experiencing such a life-changing diagnosis that can, literally take your life, that these other things are at the forefront of your mind. That, I have learned, I also talk about scanxiety with my patients all the time, and the existential experience of having cancer and then surviving cancer, and whether people even want to be called cancer survivors, or they're afraid to even claim that term because there's always that fear of recurrence. And that's something we talk about a lot in my clinic. But as you mentioned, the logistical gymnastics that patients have to navigate when they are very sick, I mean, that is the real reason that I wrote this book.
It's like, I'm curious, before we get into some of like your findings as you were like digging deep into the healthcare system. Obviously you wrote from your own experience, but you also, dug into the reality of the situation for a lot of people. I'm curious how you think that COVID screwed a lot of people over, because certain, surgeries and biopsies and things had to be canceled during the peak of it. But in some ways, I feel very lucky that when I started going in more specifically to psycho-oncology, it became more accepted that I could see, from a therapeutic perspective, see the clients that I was working with via telehealth. Like, I feel like it opened up a lot because they didn't have to leave their houses. They were sick. They could talk to me while they were in bed. I didn't have to go bedside in the infusion room where there's no privacy. They didn't have to make a separate appointment to come to the hospital just to sit in a room for therapy. They could have done it. They did it from home. What a beautiful thing to be able to do.
I completely agree. I think that was one of the silver linings, if I can, use that term about something so devastating like the pandemic. I think there were a couple, actually. I think the use of telehealth is certainly one. I think the pandemic also just exposed so many of the cracks that were already present in the healthcare system. And it got people talking about them, I think, in a more meaningful way, because suddenly it was like everybody was interacting with the healthcare system, whereas previously there was a subset of lucky, healthy people, who don't regularly interact with the healthcare system. And then COVID hit, and suddenly everybody was affected. And I agree with you. I think the telehealth was a big, it was a positive that came out of it. And I have a mix of patients now where some people I still require that they come in because it is better for the process of diagnosing to do a physical exam. So if I'm not sure about what the diagnosis is, that is actually an important part of medicine that we can't lose. However, then I have patients where we're just checking in on how they're feeling, and it's mostly a conversation. And for that, now phone calls are reimbursed for primary care physicians. That only actually changed because of COVID, where previously, if you made after-hour phone calls as a primary care doctor, that was uncompensated time. And thanks to COVID, now that's compensated. And so it has allowed doctors to communicate more regularly and with patients, and of course for patients to not drive 3 hours for maybe a 15-minute appointment where the doctor doesn't touch them at all.
Right. To say like, hey, I've been vomiting more often on this new chemo. Is that normal? Like, can I just call and hear that peace of mind? Yes, it's normal. But if X, Y, and Z happens, then make sure you come in. How many healthcare dollars, how many hours, like you said, of driving and risk of being exposed to infections in an ER or waiting for an answer does that save? I mean, just peace of mind for patients, because so much of medicine is just asking a question and needing a clarifying answer, right?
It is. And we do need to meet that better on the other side. And so I will say, in my book, I talk a lot about challenges within primary care and being the primary care doctor, where you are often expected to do all of this uncompensated work outside of the typical workday. And that has nothing to do with patients asking for help. I would never want to de-incentivize patients for asking for help, but it fundamentally has to do with a payment model that is still primarily fee for service. And in primary care, what is considered a service? A visit in the office, not a phone call, not a message, not a check-in in between. And so financially, we are de-incentivizing physicians to check in with patients because we have no time to do it and no support staff to do it. And then patients, we're now discouraging from reaching out to their doctors for help if they can't get an in-person physical appointment. You might have read there's a couple places now that are charging patients for sending messages through the portal, which was with good intention to help stem this deluge of messages that's coming on the doctor's end. But in reality, it's just creating more problems and is de-incentivizing patients for reaching out for help.
Ugh. And so obviously the elephant in the room really is the managed care system in this country. And so I'm really curious if you could share with us your experience, your take on the situation. What are some of the struggles, the failures, some of the very obvious things that you deal with on a regular basis that are obviously broken?
Yeah. And so I'm so glad you asked that question. I write in the book that it has become a cliche to say that healthcare is broken, but the reality goes so much deeper than the political and public discourse lets on. It is broken, but more specifically, in my view, By broken, it is fragmented, meaning that there is the insertion of gaps into a patient's narrative by design, that the end result is that doctors like me are working in a constant state of being partially blindfolded and having to make really serious decisions, life and death decisions, in the absence of critical information. So I think there's a few elephants in the room. And part of the fun of writing this book was sitting down and just trying to organize and catalog what are the big barriers that are causing this fragmentation in healthcare. So I think one is how we share and organize health data. And so I can speak just very briefly on that. There's two major problems. One is that health records, so we converted paper charts to electronic medical records over a decade ago with the intention of seamlessly sharing data if patients transfer from one doctor's office to another or one hospital to another. However, there are hundreds of different electronic vendors, and when a patient moves from one facility to another, those records don't always move with them. Meaning, I can see a patient who can have literally been treated at a hospital just up the street from me, but those records, when they come to see me, don't always transfer.
And sometimes they have to pay to transfer them. Sometimes they have to request the can I tell you, I'm so sorry to interject.
No, please.
The clinic I work in uses paper charts still.
Oh,
it's horrifying. And we find sometimes when somebody is reaching out from like Social Security or a disability office in order to get records, it's like fax only. And it's like, what year is it?
That's right.
I that's still happening too.
It is. I'll just share. I came off another interview where somebody had asked me, do you know of any hospitals or doctor's offices that are still using faxes? And I just laughed and said, I still use faxes. Sometimes that is the only way that I can get information.
So bananas. And yeah, like it's cool when you're in a hospital that uses Epic or whatever software they use, and you can have access to another hospital chain because it's within the same software. But like you said, then the other one is on that other program. It's like Macs and PCs, but if there were like 50 different versions of them.
That's exactly right. And I think that leads into my second point about electronic records that's really key, is that even within one system, data is really disorganized within most EMRs or electronic medical records. So say Epic, which I've used for years. You still have to click through dozens of tabs. Sometimes information is where you expect it to be. Sometimes it's not. Sometimes it's scanned in and it's literally upside down, so you're twisting your head trying to read it. And you have to know where to click. And there was a study that came out that showed that 60% of doctors' notes are identical and therefore redundant to the previous ones. And so you have to read through all of this very scattered information that is not written like a book. There's no beginning, middle, or end. And you're clicking and clicking and clicking, trying to piece together these disparate pieces of information that are scattered throughout an electronic ecosystem. And that process is very labor intensive and error prone.
And also, by the way, and tell me if your experience is like this, because you are, a physician with a lot of experience. I was relatively new when I was working in practicum. And so I just kind of learned what I needed to know in order to do what I needed to do, which means that probably 95% of the EMR, I don't even understand how to use it. I only use what I use all the time.
So there are people who are called super users. Have you ever heard of that? So Epic has dubbed some of their users super users, who are then tasked with teaching tips and tricks to other users because they recognize that it's so complicated and convoluted that a lot of people who even use it on a regular basis don't know everything that can be done with it. And I will share one, very brief story about that, which is that, so I've been in practice. So I've been a doctor since 2015, so 8 years now. And only recently did I learn something that was actually a major problem, which is that when patients updated their medication lists through the electronic portals at home, It didn't always transfer. It only transferred basically to one part of the electronic chart. And there were
Cool.
multiple parts where I could look and see the medication list, but it didn't transfer to the place that I was looking. So patients would come in all the time and say, I would do a med rec with them, a med reconciliation, being like, are you still taking this? Are you still taking that? And they would look at me confused, being like, well, no, I updated this online. Didn't you get it? And you were looking in the wrong tab, because the medication list is actually quite redundant and it's in 12 different tabs. And only in one of the tabs was it actually updated.
Ah, so frustrating.
Right?
Oh my gosh.
It's so frustrating. And you're trying to make really important decisions with your patients that have the stakes couldn't be higher. I think when you're in medicine, the decisions that you're making are so crucial. And it's just unconscionable to me that we can be making errors, even with our best intentions, because it's disorganized.
It's so interesting. I mean, of course, I keep kind of like shifting my own frame here, but I'm thinking about the handful of times when I was working with a patient who was clearly not doing very well, but I wasn't sure what their level of insight or acceptance of their prognosis was. And I literally could not find the information about their prognosis anywhere in their EMR. And so I would have to, and sometimes I think that was an issue of a physician not clarifying. Sometimes it was a physician never having had that conversation with the patient to begin with. But so often I found myself having to make phone calls to clinicians, to oncologists who don't have the time to talk to me to say like, hey, I'm working with your patient so-and-so. We're doing therapy. They don't seem like they're doing very well, but I don't think they're accepting that, death might be imminent. And I don't know how imminent death is looking. And it was just a really tough thing to have to navigate that as the mental health professional when I couldn't find it. And I didn't feel like those conversations were ever explicit.
Yeah, it puts you in a really uncomfortable and tough spot, because your choices are just digging and digging and digging through charts, sometimes futilely and not finding anything. Or you feel like you might be bothering the oncologist, or it's just impossible to get a hold of them for so many reasons. And it's possible they weren't documenting those conversations. I mean, that is a possibility, that they were having them one-on-one, but then not really documenting all of the details of it. But how does that then affect the other members of the care team like you that need that information in order to help your patients? And I think there's so much irony here that in the age of multi-billion-dollar software that we're sitting in front of, we're still then just saying, screw it, I'm going to make a phone call. Or I talk in the book about leaving post-its on my phone because I can't find something. I need to pass on a message, and I know if I put it in the electronic portal somewhere, it might just get buried under an avalanche of noise.
And so you go analog.
Exactly. So you just say, I'm going to leave a Post-it on their desk.
It's like SCOTUS. I don't know if you remember this several years ago, but there was some big expose that like the Supreme Court wasn't, quote, on email. And the way that they communicated was literally that their pages would like run from office to office with memos, like physical memos. And I was like, whoa, what year is it?
Yeah, exactly. And so I talk in the book about all the ways we try to compensate for this. As good people, I think most people who go into medicine are good people. They're dedicated people. They go into it for a reason, and it's to help patients. And you end up having to come up with all of these workarounds just to keep a patient's story straight as best as you can and get through your day. So in addition to Post-its, I talk in the book about, 4-color pens in my pockets that are bulging with papers, because you need your own system outside of the system in order to stay organized. And then the same thing is true for patients. I talk in the book about a patient that saw me with a briefcase with these multiple color-coded binders of all of her health data, because she understood very deeply at that point that whenever she came into any healthcare facility, the responsibility was fully hers to keep track of her own medical data and story, and that her physicians and other providers might not have access to it, or even if they have access to it, it could get buried and they might not know where to look. And so she took on that responsibility herself. And that just goes back to how tragic it is. And that's what I try to capture in this book, in addition to the problem of medical errors and near misses, just that tragedy of these huge burdens being placed on people when they are sick. And the focus should not be on keeping your binders together. It should be on recovery.
And the sad thing is, I feel like, and maybe it was a biased sample, but when I was working, and hopefully when I will be working again, in that specific capacity, that felt almost like the norm, not the exception, especially among patients who were stage 3, stage 4, had recurrences, for whom this was not their first rodeo. It was the norm for them to have this, whatever their system was, binders. They all had binders, and they all had their med lists, and they all had, all of their records in front of them, because they couldn't trust that their doctors would be able to pull them up.
Right. And then think about people who can't do that. And so the other tragedy here is so it's hard enough for people who are able to navigate this landscape to do it. But then there are people that just can't do it for numerous reasons. And recently I saw in my clinic a patient who was in her late 60s. She had just been diagnosed with mild cognitive impairment, which is a precursor to dementia. And at the end of our visit, we tried to address a multitude of medical issues, and I gave her a list of to-dos. In the fragmented system that we have, you actually have to go to a different place, to get this done, and then bring the data to me, print it out, bring it back to me, go to a pharmacy here, etc. And we went over the list, and she said, okay, but then she asked me again, okay, what are the steps? And we went over the list again. And then she asked me, she said, okay. And then she said, what are the steps? And by the third ask, my heart was breaking, but I also had other patients to see, and I had to move on. And it was like I could see the gulf of our fragmented medical system just enveloping her. And she was going to fall through the cracks, even despite my best efforts, because our system is not set up for people who can't take on these burdens themselves, to navigate complexity, to do so.
And there's so many reasons for that: financial, cognitive, immigration status. Some of my clients are unhoused, and it's like they don't have access. They can't just go print something.
Exactly.
They carry everything they own on their person. And so there are so many different reasons that I see all the time. It's one of the reasons that in psychology, I so admire and respect my colleagues that are social workers. I don't know how they do it, because they're basically trying to hold together a bunch of, as you use the term, fragmented pieces of the system with like gum and tape.
That's such a good way of describing it. And I have such love and appreciation for the social workers that I work with, who frequently go above and beyond what their job description is, just to try to hold these pieces together. So actually, in that story I just told about my patient with mild cognitive impairment, the very person I reached out to next after she left my office was our social worker. And I was like, please help in any way you can. Please call her. Please check in. Please, let's go over the steps with her. And they did. And there were still barriers. She didn't have a phone. So I said, please call her, but they didn't know what number to call. But I have so much appreciation for those crucial members of the healthcare team that can help keep the pieces together when there's no system in place to do it. And sometimes that's the social worker. Sometimes it's a really dedicated nurse. Sometimes it's the physician. Sometimes it's the patient. Sometimes it's the patient's spouse. And then sometimes there's nobody. And the pieces will fall through the cracks, even despite everybody's best efforts and hours of labor.
Can I bring up something else that I feel like, when it comes to the fragmented nature of our healthcare system, is something for me personally, because of my bias, that I struggle with immensely. Not for nothing, but I literally cannot work in hospice care as a psychologist because Medicare won't reimburse psychologists. So that's fun. They'll only reimburse master's level clinicians. And that's just the nature of the thing. So as somebody who's really interested in working in end of life, I find myself drawn towards oncology, and palliative psychology, not because oncology or palliative care literally have anything to do with end of life. So much of both of those fields is working with people who are in active treatment or who are in survivorship. But of course, there is a component where people die. They die from their cancer. They die from, their life-limiting diseases. And these are the people that I often work with because I'm an existentially oriented clinician. That said, one of the things that kills me is when I'm working with a client within a cancer facility, and then it's very clear that it's time for them to go into hospice, but they don't want to because they don't want a whole new care team.
Yeah,
it's so heartbreaking.
Yeah, I unfortunately do deal with this a lot in my practice as well. So as a cancer survivorship doctor, survivorship covers the whole spectrum. So you are considered a cancer survivor from the day of diagnosis. You are considered a cancer survivor if you are cured of your cancer. And you are also considered a cancer survivor if you are living with metastatic disease that is progressing. And so in that case, I'm often the person who's having the conversation with my patients about now hospice might be the next best step for you when we don't have any more cancer fighting treatments that are going to significantly slow this down or improve your quality of life. And I've had patients that have not wanted to go on hospice because their very first question is, can I still see you if I'm on hospice? And, I don't say that to toot my own horn or to promote myself, but you develop these relationships with your patients over the years where you become hopefully the person that they trust. And I've guided them through so many ups and downs of their illness. And then they're afraid to go on hospice, which can provide so many good resources that are really,
hospice is
really
incredible.
needed.
It's incredible.
But then sometimes it depends on the hospice, but some hospices will not reimburse for patients then to come back and see me. Some will. And so then again, it's navigating the logistics. And I say, we have to check with this hospice whether coming back to see me is something that can be reimbursed. And that can be a huge factor in their decision making. And if they get hospice, it's like you said, there's so many amazing resources that come along with it. That's really good. But then you're losing sometimes the doctor that's been with you that whole time through all the ups and downs. But then if you decline hospice, you stick with that doctor, but I'm just one person. I'm just a doctor. I'm not the nurse that can be there on call if something comes up in the middle of the night. And
you can't provide services to the family, and hospice can't. There's so many things hospice can do that you just as one person can't do. And like, as you mentioned, sometimes hospice will reimburse your services, sometimes they won't, which is a barrier, but the entire other team, let's say their infusion nurse, they're really, really close to it. That's not going to be your hospice nurse. Let's say their psychotherapist, they can't follow you into hospice necessarily. There's so many members, the social worker, there's so many members of the care team that, cancer, people who have cancer, it's a full-time job. They're in and out of the hospital all the time. They know these people on first name bases. They know the names of their children, and it's like so scary to say overnight, even though I'm going to get in some ways more wraparound care, really intensive palliative support, bars installed in my bathroom, therapeutic support for my surviving loved ones when I do die. It's hard to say goodbye to a care team that you've known for sometimes 10, 15 years as you're living with cancer. It's a huge ask.
It is. And, I see the same thing actually at the transition point when somebody finishes their treatment, like finally finishes their chemotherapy or radiation, and then they're referred to me for the cancer survivorship phase. And sometimes they're scared because they want to stick with the oncology team that they've known all along. And even though the oncology team can, promote me, you're going to love Dr. Yurkiewicz, I promise. transition is really hard for people. And I think, that is something I write a lot in the book about too, is how we've become so subspecialized in medicine now that, again, if you have a serious illness, you are often ending up with multiple new faces on a regular basis and not knowing who's your primary. And sometimes there is no clear primary, and no one person might be taking ownership over the patient's full narrative as they're going back and forth between different members of the care team that are all looking at their one piece, their one slice, and they might be doing that expertly and perfectly and thinking very logically, but you still need one person to kind of oversee the whole story. And a lot of people do not get that. And our healthcare system is not designed to promote that.
Yeah, I can, reinforce that 100%, because as somebody on the mental health team, you hear all of it. And, it's like I see them sometimes once a week, an hour a week, more than they see other, clinicians. And sometimes myself, or very often the social workers, almost feel that weight of being that wraparound person. Although, we're not empowered to do that. It's not our job. We're not physicians. So there are certain things that's beyond our scope to ever speak to. And it's heartbreaking to see the confusion in our clients' faces when they're like, wait, who do I talk to about that? Who do I get? And it's like, we can only give so much advice ethically about that.
Mm-hmm. But look how much that shows about the beautiful relationships that you've built with your clients and patients and how much they trust you. And I really appreciate you saying that and drawing those clear boundaries about what you can and cannot say. I think the key point here is then who are you sending them back to? When
exactly.
they ask. Yeah. And there can be a lot of confusion, even among doctors, to answering that question. Like, who is the person who's actually making these higher level decisions? And from working in healthcare so long, I've seen how so much of this is just miscommunication between different team members. And sometimes you can just be one person who decides to take ownership. And just by making that decision and being the physician that decides to decide, you can play a really powerful role in patient care.
Oh, 100%. We're talking about oncology a lot because that is your specialty, and it's something I've been starting to develop more of a specialty in. But I'm finishing my dissertation right now. I'm about to defend it, and I interview people who die with medical aid. This is legal in 11 states in the U.S., California being one of them. And one of the things that I noticed when I was talking to a lot of the participants in my study was a refrain of, I didn't know how to talk to my oncologist about this because I felt like their whole job was to try to keep me alive. And when it was time to start talking about how do I want to die, I didn't know who to go to. I didn't have that person who I felt like was in my corner for that. And it was so heartbreaking to hear that, because maybe they never were lucky enough to have a palliative consult, or maybe they just didn't know their palliative physician, or maybe their oncologist would have been very happy to have that conversation, but they didn't know they could, or maybe their oncologist was completely uncomfortable having that conversation. But that was just another beautiful example of a time when that overarching view, that sort of point person, felt like it was missing. And so they felt very, very alone in wanting to talk about this very difficult decision they had to make.
Yeah. And I'll share that's something. So medical aid in dying is something that I have prescribed twice in my career. And in one of the cases, I was with the patient in her home on a Sunday morning when she decided to use it. And it was actually such a gift in the end to be able to be present and to be able to talk to her about that decision and that really, really hard thing to talk about, which is giving up. Well, the idea, I think, is giving up on treatment, giving up on chemotherapy or giving up on radiation therapy. But you're not giving up. You're focusing on something else. And, the literature shows quite clearly that often people can live longer when they go towards palliative care, when they have metastatic disease, the details really depend on what kind of cancer it is and the treatments that we have available. But people can live longer and they can live better. And it ended up being this beautiful gift for her and for me and for her family to be able to give her this choice, which let her have agency over the very final chapter of her life. And being there for it, I was thinking, if everybody had this experience, I was a supporter of medical aid in dying before I ever prescribed it in theory, but going through the experience, just even more so, I was such a believer that she had this opportunity to do it on her own terms, and that I was able to help guide her through that really hard decision.
Oh, I love that. And I feel very similarly. I was an advocate beforehand. I wrote that in my dissertation as my sort of like bias going in. And of course, after talking to these incredible people who are choosing this path, it only sort of reinforced the value of having choice. And I think that in some ways, I think about the ones who said that it was a really easy process for them, who have felt supportive, very often the ones who chose hospice when it was time to choose hospice and worked with hospices that offered this as a supportive option. I wonder, not to kind of switch gears, but I do think it relates. Moving into solutions, right? How do we defragment or unfragment or reunify a fragmented system? One of the easiest places my head goes is single payer. It goes universal healthcare. But before we even dive into anything political, we have that in this country. Medicare is that in one way, even though a lot of it's farmed out to individual insurers, and it is sort of a hybrid managed care, universal healthcare kind of thing. But specifically hospice, when done right, do you see that as sort of a model for an unfragmented system, albeit only 6 months in the person's life that they get access to it?
Yes, it is.
I love that.
It is a model that you still have to transition into, right? So there's that layer of fragmentation right there, like we were talking about, when you have to decide that you're not going to see your old care team anymore and you're going to go with this new care team, which is the hospice team. But then, yes, once you are on hospice, it's kind of a one-stop shop for everything that the patient needs, which is the ideal model. And, you talked earlier about, a system where everything is in one place. The dietitian is there, the social worker is there, the physician is there, the nurse is there. And, hospice provides so much of that model too, where it's you call one number and they will send the right person. And they have a care team that is seamlessly communicating with each other. And they have a small enough number of patients that they can get to know their patients well, which is kind of another issue that I don't want to veer too far off course. But I will say that that is a huge problem for why our system is so fragmented, and getting towards solutions is getting back to a payment model. And a payment model of fee for service that not only reimburses for the office visit, but often reimburses higher to see a new patient than to see a patient you're following up with, incentivizes administrators to then stack their doctor schedules with back-to-back new patient visits. And then an average primary care doctor ends up seeing over 2,000 patients in their panel, and you can't know any one of those people well.
Jesus, is that the number really on your panel? That's amazing. Or like the average number?
Yeah, on mine, it's more like a very low 1,300 right now.
Wow. I can't lucky. Oh my gosh. I can't imagine. And not to, we'll come back to the hospice thing, like put a pin in it, but I feel like I need to respond to that too. I see this all the time with clients, like working in mental health in psychology, right? I'm not a prescriber. Like that's not how it works. It's a PhD title. It's not an MD. I'm not a physician. And so I support my clients in their mental health with their psychiatrists and often work with them. But I'm posed this question a lot from patients, like, can my psychiatrist do therapy? And it's like, yeah, they can, but very often they don't because they can't afford to. the way they get reimbursed makes so much more sense for them to do a med check for 15 minutes with their clients than to sit down and do an hour of therapy. Although a lot of psychiatrists are trained in it, the model doesn't incentivize them to do it. And my version of that as a psychotherapist is that I will not be on a panel very likely. I'm going to have to be private pay, which is a very common thing for psychologists because you can't make ends meet on panels. And it's not fair. I don't want to only see the people that can afford me. So you end up seeing these people that have a hybrid model where they're private pay for a huge percentage, and then they're sliding scale and even pro bono or going into community mental health and working for free so that they at least feel like they're doing good in the world. And it's gross. Like, I hate that we have to be the ones who make that decision.
That's right. You're facing your lose-lose options. And I think there's an analogy here in primary care. I will tell you that, pretty much every primary care doctor I've talked to, interviewing for this book or otherwise, at some point in their career has considered going to concierge medicine. Yeah. And they don't want to, but that is the only payment model where then they can cap their practice at 200 or 300 patients instead of 2,000 patients. And then they can treat each one of those 200 patients better because they're not thinking constantly about the reimbursement. And again, like I said, the schedule being stacked with new patient visits up to 2,000. And they don't want to go into concierge medicine because it feels kind of icky for a lot of people to then only treat people. I have a colleague who went into concierge medicine, and she said, I wouldn't be able to afford me. And that's
exactly.
And
so you end up treating like I see all the time, at least in psychotherapy, you end up treating the worried well. That's not who I want to treat. I want to treat people who are sick, like really sick.
Yeah, it's not what we were trained to do. And it's very sad that then your choices are to stay within the system that reimburses very sporadically in a way that doesn't often make sense, whether it's for mental health support or primary care services that only reimburse for the office visit and nothing else. That's one choice. Or then you have to go private or go concierge or direct primary care, where then you're selecting for a patient population that is not as gratifying to see.
So, we mentioned how hospice is like a microcosm of a sort of more integrated care model. And of course, I feel like anybody listening to this show from Europe or South America or Canada or like a lot of places in this world are probably like, what are you guys talking about? And so I'm really curious where you stand, how you feel, and what you're comfortable saying with regards to the managed care system here versus some of the healthcare system models that we see in other, let's say, developed countries, but honestly, even in developing countries.
Yeah, I think it's pretty obvious that how things are going in the US, it's not working. And the payment model is a huge piece of that. And in single payer systems, look, it's very complicated. I think they have their own problems. Yeah, I think of it kind of like Winston Churchill's definition of democracy, which is it's the worst form of government except for all the other ones that have been tried. Mm-hmm. So I think that has to, be a part of the solution here. In the US, where the incentives lead doctors and other members of the care team in all sorts of wonky directions. Where you end up sending somebody to the ER because it reimburses more than seeing them in clinic and keeping them healthy. That obviously doesn't make any sense. And then for patients, we talked a bit before about financial toxicity and navigating that when they're also very critically ill. And I have seen my patients go bankrupt, even when they are insured from the cost of medical care, which is, that's wild. That's wild.
That should never happen. Terrible. Like even good insurance, like they're paying their premiums, they're doing everything. And you see these examples of people who I had to choose to only reattach my ring finger because I could not afford to reattach my ring finger. Like this was in Sicko in the Michael Moore documentary. And of course that's an extreme example, but very often you'll hear stories of people being like, My ambulance wasn't reimbursed because I didn't pre-approve it. Well, I was unconscious on the floor. How could I pre-approve it? Like, it's just bananas. And you talk about incentives for doctors. What about the health insurers? And the incentivization is so bastardized.
Yeah, absolutely. I mean, so much of the problem here is actually how our system is set up primarily for billing and not for patient care. And that goes back to the tech issue too. I mean, just getting back to the electronic records for a second, because I think this is very related. The idea is, when I was doing research on kind of how we got to this really messy state of record keeping that we're in now, the original sin, in my view, was designing it for billing rather than for patient care. And when we're trying to stimulate as a country, it sounds great on paper to go away from paper and towards electronic medical records. Everyone supported in theory. It sounds great. But then the government, the federal agency behind the operation, set this whole slew of metrics that had to be met in order for hospitals to receive reimbursement. And those were things like a smoking status, family history that weren't always relevant, right? Like if you're seeing somebody for end of life care or a simple cold, you don't need to know and document all of these things. And so while standardization was good in theory, it ended up just cluttering and littering the electronic medical records so that then important information got buried. And so I do see the original sin there of why our tech is so disorganized. Also going back to the issue of billing, it was designed for hospitals to get reimbursed and not for meaningful use, truly meaningful use of patient data for doctors to make decisions.
Yeah. And it's like, I don't want to put you on the spot or ask you an uncomfortable question. So feel free to decline answering this. And obviously we could even, I don't know, edit it out if you do decline. But I'm just really curious and, not to get into your politics or your ideologies, but like, is the failure here that healthcare in our country is for profit? Like, and I get that there's always going to be private pay and concierge medicine, and there should be maybe a capitalistic for-profit sector, but is basic healthcare, shouldn't it be a human right? Shouldn't it be something that we can all access and that we shouldn't be making money off of people's sickness?
Yeah, I mean, these are definitely bigger questions just about capitalism and whether our entire system of how we think about, what's a right and what we should work for in this country, kind of our ideology there. But yes, it is a huge problem that so many health organizations are for profit because it incentivizes everybody in all the wrong directions. And it has led us to a system where we are now, where doctors are burning out and quitting in droves because of burnout from all the bureaucratic tasks. And patients are going bankrupt even when they have insurance. And so I think I will say this. I do talk in the book about there was a law called EMTALA from the 1980s where it's basically kind of getting at the question, is healthcare a human right? And EMTALA said that emergency care kind of is a human right. You can't turn someone away from the emergency room when they have an actual medical emergency going on. So we have decided as a country that there are some parts of medical care that are considered just so rights-based that nobody can turn you away. However, there's no related EMTALA for follow-up. You can be turned away from the emergency room, but you can be turned away if you want the treatment, the chemotherapy that would have prevented the oncologic emergency that you're going in for, or the insulin that would have prevented the diabetic coma that you were going in for. And so I think that way of thinking is very problematic, that we have defined emergencies in this very narrow way. And we have declared that some medical care is patients just have a right to get it. But what do they have a right to get? What is actually an emergency? And I do get into that distinction a bit in the book. And in my view, follow-up care just needs to be prioritized so much more as the medical emergency that it is.
Right. And also, like, to be fair, and I'm just looking at this from a pure numbers perspective, like even removing emotion out of it, which I cannot do, I physically am incapable of, but I'm going to pretend I'm capable of it. That very ethic is completely decoupled from the financial model. So what we end up doing is paying for it post hoc, which ends up making inhalers cost $150 downstream. You know, if we were actually a priori building in a system that allowed for healthcare at the most basic levels, we wouldn't be overburdening a system that was never built for it after the fact. And that's the part that I just get so frustrated by. Like you mentioned, you know, the way that this affects physicians, the way that it affects management in hospitals, the way that it affects all these different aspects. We didn't even talk about pharma, the way that, like, because the way our system is structured, the incentivization for making more statins and you know, changing a little molecule in it and remarketing it as a new version is more cost effective and more interesting to the pharmaceutical companies than making new antibiotics. That
Yeah,
sucks.
because the costs are not all coming from the same pool. And
Yeah,
so,
and when somebody has a chronic illness, they're going to keep buying the meds. You know, when you want to just treat somebody once, it's a one-shop customer. There's no incentive there, because as long as the profit is out in front of all of this, the decisions are, I mean, even if we pretend they're not, we're going to be making decisions based on how do we make the most money, right?
I agree. And
Ugh.
that's a huge problem. And something we didn't get into too deeply here is the effect on burnout for doctors,
Yeah.
and not just the decision, should I go into concierge medicine or not, but all of that uncompensated, like how the system reimburses now, creates all this uncompensated work for doctors to do that is directly contributing to why they are burning out and leaving. And so I cite in my book that almost half of doctors are burnt out. And the number one cause is bureaucratic tasks. And that has stayed true both before and during the COVID pandemic. And that has to do a lot with the tech problems, but it also has to do with a financial model that reimburses doctors to see patients face to face, but then doesn't reimburse for anything else, like we talked about, like those phone calls or those check-ins or sending messages or doing the work of sleuthing through the electronic charts. It doesn't reimburse for any of that. And so doctors end up taking hours of work home with them on nights and weekends, because during the day, they're stacked with seeing only things that are reimbursable, which tends to be the face-to-face visit. And all this work needs to get done at some point, and it ends up being done on doctors' nights and weekends. And that is a direct reason why they are burning out, even after, you know, a decade of training and all of this expertise that has accumulated. And they're quitting. They're quitting in droves.
Oh, I was seeing signs, like I can attest to this as somebody who's had a recent partner who was in residency, and I was already seeing signs of burnout during their residency. Like, that sucks. That's really worrisome. And the sad thing about burnout, and I'm so glad that you highlighted this because I think it's an important thing that we all need to grapple with, is that burnout is more often than not a failure of self-care.
No.
It's not a failure of work-life balance. It's a systemic structural failure that so sadly is often attempted to be solved by promoting self-care. And it makes people feel gaslighted and disempowered.
Yeah, the medical establishment often responds to burnout with things like do yoga or have an ice cream social or get therapy. And look, I'm never going to turn down ice cream. I'll go on record now saying that. I will accept the free ice cream. That sounds great. However, that is not why doctors are burnt out. And so that is not the solution for burnout. And you're right, it makes people question themselves and whether they're not cut out for medicine, when in fact there's all of these obstacles that have nothing to do with you, of why you're burnt out, which is many, many hours of work that are uncompensated and are clerical when you were trained to do, you know, higher level things. And you go into medicine to help people and save lives, not to do paperwork at 11 p.m. And it is not a solution to make it the task of the individual to try to solve it themselves. The solution for burnout is revamping the system in several ways. It's getting better tech support so that the technology should be doing what doctors are now doing manually. It's getting better team support, just like we talked about in the hospice model, where some of these tasks can be delegated to different members of the healthcare team, and it doesn't need to be the doctor who's sleuthing through the charts. And then it's getting more time and compensated time to do all of these tasks.
100%. Gosh, there's so much to think about. You covered so many important aspects of these failures. So I know that we're basically out of time, but I was hoping that maybe you could enlighten us a little bit about some of the choices that you've made within your own practice, some of the recommendations that you're making for your peers and for your colleagues about, obviously you're not going to solve this problem, but how can you soften it a little bit? What are some of the things you're doing to try and affect change?
Yeah, so I talk to my patients frequently. I say to them that the only guaranteed source of continuity in your own medical care is you. And while I don't advocate that it should be this way, this is the current reality. And so I have a 3-page checklist in the back of my book that is the full patient story. And it's something that I talk to patients about on a regular basis. This is the information about yourself that you should have on hand. It's almost like an elevator pitch of your medical history, so that every time you see a new provider and assume that it's all in the electronic chart, and it's not, you're able to best help your doctors help you. So I would say that's one, is empowering patients to be the shepherd of their medical story, even though it's not fair and it's not right. But given the system as it stands, they will get better care if they know key facts of their medical history. The other thing that I talk about in the book that I think is important is as professionals in this system. So that's advice that I give for patients. But as professionals in this system, despite all of the barriers that we talk about, the insurance barriers, the scheduling barriers, the bureaucratic work, there's also a mindset of thinking big picture about patient care that I very much believe can be taught and can be developed. And so even if you have multiple specialists and multiple doctors involved in a patient's care, you can be the doctor that kind of just looks at your own slice, that looks at the body part or the organ system and just stops there. Or you can try to reconcile different narratives told by other doctors and put the pieces together to see if they add up to a reasonable conclusion. And I do think the empowering fact of the matter is that any doctor can do that. It doesn't necessarily need to be a generalist. A specialist can do that. And I believe this is a mindset that kind of defragments how you look at a patient's story that can be learned. And it's something I work with a lot of residents now, and I try to encourage them to do in their patient care.
I love that. And it's almost like the ethic of palliative medicine. You know what I mean? It's like every physician can also be a palliative physician. They can be thinking about quality of life for their patients and thinking about ways that their patients can live fuller, more complete lives, and how medicine can be a vehicle for that. And it's just such doctors really do have so much power. I know in so many ways you're disempowered, but I think sometimes focusing on that, the shortcomings and the failures, you lose the obvious truth, which is that sitting in the room with a patient and telling them what you see and being there for them, putting your hands on them, like it's like with my ex, I used to tell him, you need to wear your stethoscope. He's a neurologist. You need to wear your stethoscope because this might be the only time this person has their chest listened to. They might never see anybody else. And I know it's hard and you don't have time, but there is so much power in being a physician because you change the course of this person's life. And so many people trust their doctors just implicitly.
I think that's so beautifully put, Kara, and I agree 100%. And I think so much of the power of being a physician is in presence. And it's not always exactly what you say or what you do. And sometimes it's just being present and being a witness to what someone is sharing and what the suffering of the journey that they're going through is. And we can establish that rapport, I think, pretty quickly if you just show that you are listening and you are present and you are on their side, whatever decision they make.
Ugh, agree 100%. Well, everybody, I don't want to keep any longer. It's already been over an hour, but I could, like I said at the beginning, talk to you for so many hours. Everybody, the book is Fragmented, A Doctor's Quest to Piece Together American Healthcare. Such an important book. If you're living here in the States and you've ever experienced this, because I know you have, and you want to learn more, you want to, hear about some of these solutions, or if you're curious because you live outside of the States and American healthcare has always baffled you, I think that this is also an important read by Dr. Ilana Yurkiewicz. Did I say it right?
Perfect.
I tried. Oh, good. Yay. Gosh.
Thank you for having me.
Of course. Thank you for being here. It meant so much. And as I'm entering into a new phase of my career, I really appreciate it just personally and selfishly because I need these reminders. And so I appreciate that guidance as well.
I'm so glad that your mindset is already there and you are going to be amazing and your patients are lucky to have you.
Well, thank you. And your patients are so incredibly lucky to have you. And everybody listening, I'm lucky that you come here week after week. I'm really looking forward to the next time we all get together to talk nerdy.